First of all, I want to thank you for the opportunity to be here this evening and to speak with you. I'm very impressed at the numbers that have turned out, and I understand it's usually this large, and that's just excellent. I think it's very important to understand when we're going through something like prostate cancer or for women's issues, in which I primarily deal with, that we're not alone and that other people are dealing with the same things, and we can learn from each other and get encouragement and support from each other. So I'm just really impressed with this group and the size of you, and it's at least it's not blizzarding outside, so it's good that you all turned out tonight. Sure, I can. Yeah. Well, I was just going to tell you a little bit about myself. I do have a lot of women in my life dealing at the pelvic floor clinic. We see women with urinary incontinence issues as well as other pelvic floor issues. I have 4 daughters. I have 2 female cats. I have a neutered dog. I have a mare horse and a gelding. But I have 1 husband, 2 sons-in-laws, and I have 6 brothers. So I'm just trying to balance things out, I guess. So what we're going to do tonight is we're going to briefly review the male pelvic anatomy, review the types of incontinence, because there are more than just one, review the risk factors for incontinence, and then review some steps that can help reduce incontinence and prevent it from worsening. So we'll just move along here. Basically, we're going to talk about what's normal, what's not normal, and what we can do about it. So sort of 3 areas is what I usually break down presentations on. Now, I'm sure you're fairly familiar with the anatomy here. I'm usually dealing with women, so I'm usually dealing with women's pictures, not men's. And obviously, the major difference, of course, is the prostate gland surrounding the upper portion of the urethra. So here you have the bladder, the urethra, the scrotum and the testicles. And then what we're going to really talk about is this group of muscles just at the base here of the prostate gland, because that is the one factor that you have some degree of control over and some degree of strengthening and improving some of the incontinence issues you have. The actual bladder is a very interesting structure. It varies in size and location and shape, depending, of course, on how full or empty it is. I have a nice little model of a bladder, but it never really looks like that in real life. It varies a lot. Now, the bladder doesn't create urine, the kidneys do, and they're located higher up in the body and drain into the bladder via the ureter. So what the bladder really is simply a reservoir or storage tank for urine that is created by your kidneys, and they work 24 hours a day. So even as you're emptying your bladder, it's being refilled and replenished, so it's never entirely empty or stone dry. Now, the bladder itself has 3 layers. It has an outer fatty connective tissue layer. The main part of the bladder is muscle, though. It's called the detrusor muscle. It's a smooth muscle, and as you know, muscles contract and muscles relax, and the bladder does the same. It contracts to empty, and it's relaxed the rest of the time as it's being filled up from the kidneys. The lining of the bladder is a very sensitive mucous membrane lining, and it is sensitive to the urine, to things in the urine, to things that we eat, that we drink, that we smoke. It affects the urine, and it then affects the lining of the bladder, and it affects the functioning of the bladder. Now, the bladder drains through the urethra. In women, the urethra is quite short. In the male, it's a fair bit longer. And then here again, you can very nicely see how the prostate gland is kind of like a donut encircling the upper portion of the urethra. And of course, if it enlarges or changes or develops cancer, that type of thing, it can definitely affect the tube, the urethra, that is draining through the center of the prostate gland. Now, the external urethral sphincter is what we're going to be talking mostly about, because that is what, when we're children, boys and girls, we learn to relax when we want to empty our bladders, and we learn to tighten when we're holding our urine. And it is a muscle that we learn to tighten and relax. And that muscle, as any muscle, needs to be used throughout our lifespan, or it gets weak and it gets lazy. And that is sometimes a muscle we have to revive and get back to work after a spell if we've sort of forgotten that exists and forgotten how to actually locate it and use it again. Just move on. The actual process of emptying our bladder is quite complicated. It has to do with centers in our brain, centers in our spine, in our pelvic floor, nerves that are descending, nerves that are ascending, stretch receptors, a whole variety of things, and we're certainly not here today to go into those details. But it is a fairly complicated system and really not even completely understood. But we're going to break it down to the very basics. And so then we have, in a normal bladder, we have two phases. We have the storage phase and we have the emptying phase. So in the storage phase, the detrusor muscle of the bladder is relaxed. The kidneys are working, draining through the ureters into our bladder. It's slowly being filled. Everything is sort of in a relaxed mode, but relaxed in a sense that the bladder is relaxed, but we are keeping the urine in the bladder by the tone in our pelvic floor muscles and in the sphincter muscles. At some point, the bladder fills to a point where you're aware that there's something in there, that you sort of notice that I'm going to have to use the bathroom fairly soon. The muscle is still relaxed at that point, but the urethral sphincter is starting to sort of contract a little bit because you're trying to really keep the urine in the bladder. You can't just let it drain out completely. And then again, if everything is working normally, when our bladder is full enough to empty, we find a bathroom, we relax our pelvic floor muscles, we relax the sphincter muscles, and the detrusor muscle then contracts. So it squeezes, pushes the urine out, and then you have the wave here of the urine draining, emptying the bladder almost completely in most cases if everything is functioning normally. And then we start back at square one with the bladder storage phase, the bladder filling phase. So that is sort of the way things should be working in a normal basis. So here you notice the pressure in the bladder is nice and low. It increases because the muscle is pushing the urine out. It increases and then it relaxes back down. So that's kind of what's normal. Now we're going to talk about the types of incontinence briefly. The most common type of incontinence after prostate surgery is stress incontinence, but there's other kinds that we definitely see, and I'm sure some of you are affected by. Urge incontinence is also called overactive bladder, or OAB, so it's an interchangeable term. Mixed incontinence is a combination of the first two. And that's probably the most common thing entirely, that most people have mixed to some degree. It might be 90% stress and 10% overactive bladder, or 50-50, or some degree of both types of incontinence. Then there's a couple of other types called overflow and functional, and we'll just talk about what they are. Now some of you are like, this piggy, I have to go wee, wee, wee all the way home, and that's... Stress incontinence is when you leak or spurt urine when you put sort of physical stress on the bladder from things like coughing, sneezing, jumping, doing any kind of sports, running. It is most common in women. It tends to start at a younger age, but it occurs in men following prostate surgery. That's the most common type after following surgery. So people with stress incontinence may not need to void urgently. They may not need to go very frequently, just what's considered normal. But whenever they do anything like coughing, sneezing, whatever, that's when the urine spurts out. It can be a leak, it can be a gush, it can be quite a large amount in some cases and start the whole thing happening. But that's called stress incontinence, the most common type. So here you see, it's actually a female bladder, but it applies to the male bladder as well. Here you see a bladder where the pelvic floor muscles that intersect around the urethra have gotten a little bit weak. And what happens then when stress is put on the bladder, a cough, a sneeze, whatever pushes down on the bladder, these muscles do not compensate by squeezing and holding the urine, and that's when the urine spurts. So here you see some pelvic floor muscles that are much thicker, that are much stronger. It's kind of like pinching off a hose to stop a leak. So when that cough or sneeze or movement comes, those muscles are able to contain the urine, and even though there's pressure on the bladder, the squeezing power is strong enough to withstand that pressure and no leakage occurs. So that's sort of the goal, I guess, of working with stress incontinence. Overactive bladder or urge incontinence, people would describe it as when they get a strong, sudden urge to empty their bladder, and they may or may not be able to hold it when they hit the toilet. until they get to the toilet. So those are the people in Calgary, and I've had many women say this to me in the past. I know where every public washroom in Calgary is. Because the first thing they do when they go somewhere is they check out the bathrooms, because they know when they're going to need them, they're going to need them instantly. They're not going to have time to ask for help or to try and find it. A common feature of urge incontinence as well is when people arrive at home, they call it latchkey syndrome. They have a hard time making it in the door of their house. They drop everything, head to the bathroom first, then they, close the car door and everything else that goes along with it. As a result, people with urge incontinence or overactive bladder often go more frequently because they go whenever the urge tells them to. So they might go every half hour, every hour, and they may feel sometimes they're not even emptying properly or completely because they always have that urge to go again and again. And often people with urge incontinence have more trouble at night, getting up at night. Mixed incontinence, as I said earlier, a combination of stress and urge in varying degrees. Now, overflow incontinence is a little bit different. It tends to result from overstretched bladders or from obstruction around the urethra. So the bladder, instead of holding its normal amount of approximately 1 to 2 cups, can hold 4 or 6 cups in some cases, because the bladder can be overstretched and it can get used to holding larger amounts. It becomes like a balloon that's been blown up again and again and again. It's huge. But then it never sort of deflates properly and goes back to its normal size, and the tone becomes very poor and it doesn't function. So what's happening in essence is that there's just a bit of overflow urine that's draining out, and there's a lot of urine sitting in the bladder most of the time. It sort of does its own thing, and there's very little awareness of the need to go, of the sensations that should be normally telling you it's time to go and that you're empty and that type of thing. So that's called overflow incontinence. And I often warn nurses about this, because nurses, doctors, teachers, bank tellers, cashiers, people who can't go to the bathroom when they need to, they have to wait for their break or wait for lunchtime or relief at the till or something like that. So their bladder gets fuller and fuller. And normally the urge to void starts, it gets very strong, but then it tends to ease off again. And then later it'll come back. So it comes, they need to go, but then they forget about it and wait till later. So it's as a result of overstretching the bladder, whether it is from some obstruction so it doesn't drain properly, it just overfills, or from just sort of a bad habit of not going often enough. Functional incontinence really has to do with getting to the bathroom, not so much to do with the bladder itself, but the fact that sometimes people need assistance, they need help from a caregiver, a walker, a wheelchair, cane, it takes longer to get there, and they just simply can't hold on long enough until they get to the toilet. So those are the types of incontinence. So these are the risk factors for urinary incontinence. Getting older is certainly a risk factor. It doesn't mean it has to happen with everybody as they age, but it does tend to get more common, as many ailments do, as we know. Smoking is a risk factor for incontinence issues, also for for bowel incontinence issues as well. Prostate gland enlargement has been mentioned. Pelvic surgery, including prostatectomies. Radiation can affect the functioning of the muscles and of the bladder. It's not as pliable, as stretchy, it's stiffer, it doesn't work as well. Constipation is a risk factor for urinary incontinence, and the longer I work in this area, the more it seems to me that many, many people have years of incontinence or of constipation behind them. It's the myth that you're supposed to go every day after breakfast. I think it is that a myth. It doesn't happen to many people. If it does, I'd almost like to shake your hand, because there's not many of you out there. When I was a little girl, my dad used to disappear into the bathroom with a couple of newspapers and a book and come out about an hour and a half later, and I thought that's what you did when you grew up. You had to sit there, and it just took longer. I think now that he was escaping from the family for an hour and a half, but that was his break time. But constipation is not normal. It's not a common thing that should be common for you. It shouldn't be happening on a regular basis. And the most important way to deal with constipation is to increase your fiber content, and that's sort of the natural way of dealing with constipation. Fiber increases, isn't absorbed by your body, it simply goes through your bowels, and it makes the stool a better consistency, so you're not having to strain and bear down with hard stool. Being overweight is a risk factor for urinary incontinence as well. It's hard to say how many extra pounds causes how much more incontinence and how much weight you need to lose to make a difference. It's not that scientific, but it certainly is a factor, just simply the upper body weight pushing down on the bladder, on the pelvic floor, on the muscles. Some medications that people are on can actually affect their bladder and the way it functions, and common medications like diuretics or water pills, like high blood pressure medications. Lots of people have those issues. Even medications for anxiety, for sleeping, things like that. So common things, they affect the bladder and the way it functions as well. Now, I'm not suggesting you cut those out of your regime, but you should probably look at what you're on and see if that is affecting things. Rarely is it one thing causing your incontinence. Usually it's a whole combination of different things that all combine. It's like pieces of a puzzle that you create the picture with. So the medications might be one of the factors aggravating the situation. High impact activities, which would include things like running, jumping, sports, all the things that are healthy and good for us. Unfortunately, the impact of with the ground pushing down on the pelvic floor and on the bladder itself takes its toll if it happens again and again, year after year. And so something to be aware of as a risk factor. And chronic diseases, particularly those that involve the nerves or the neurologic system. So we're looking at things like Alzheimer's disease, multiple sclerosis, Parkinson's disease, even diabetes, because the nerves are affected over time. They lose the way they function. So those are the most common risk factors. And the interventions and treatment options, that the things we can do about it include the following, and we'll go over these in some degree this evening. We're not going to have a lot of time to spend on any of them. The first thing is to get those muscles stronger again, how to rehabilitate or strengthen those pelvic floor muscles, doing the Kegel exercises, and sometimes requiring the assistance of a physiotherapist, because they're the ones that have the expertise and the true knowledge and can really help people work and deal with these issues. Fluid intake and dietary changes. So looking at some of the things that irritate that sensitive lining of the bladder that you might want to cut down on, eliminate or reduce in your diet so your bladder isn't having to work against this, the things that irritate it so much. Looking at bowel and bladder habits, bladder retraining and urge control techniques, your weight, smoking, and medications. And some of these we won't spend much time on, we'll simply mention. Okay, pelvic floor muscle exercises, doing your Kegel exercises. Incidentally, Kegel is the name of a doctor, Dr. Arnold Kegel, who in the 1940s did research and sort of discovered these muscles, I guess, and did a lot of research and helped particularly women at that stage with the pelvic floor muscles. So they're called the Kegels as a result. Where are they located? Well, to help locate them in yourself, it's best to be sitting, so you're all doing that. And what you need to do is try and squeeze the muscles which prevent you from passing gas. So that's something you can be doing, and the person next to you has no idea that you're doing it. And that's a good thing. That means that you don't need to go to the gym and take a period of time out of every day to strengthen these muscles. You can do it anytime, any place, anywhere, and no expense added. You can just do it. So I often say, pretend you're at a wedding and they're saying their vows and everything is hushed and quiet. And you think, oh no, I'm going to pass some gas, and you're squeezing for all you're worth. You're doing a Kegel exercise. The same group of muscles encircle the urethra, encircle the rectum. In women, they encircle the vagina as well, and they are also the support that holds all those abdominal contents in place. Now, when you do them, you don't need to tighten your tummy muscles. You don't need to tighten your buttocks or your thighs. When we examine people in our clinic, we always check to see if they can do this exercise. And sometimes the women just about lift themselves off the bed, and the muscles that are supposed to be tightening are just having a nice nap. So you need to learn how to isolate these muscles and just tighten the muscles that control the passage of gas or the passage of urine. So if you need to hold, you're doing the exercise properly. And you shouldn't be holding your breath or squeezing your face or making a fist. So one exercise is one squeeze plus one relax. Important to do both fast ones and slow ones. If you're going to cough or sneeze or move suddenly, you need those muscles be able to grab quickly and prevent the urine from draining out. But if you're hiking and you're still 10 minutes, at least this applies more to women than men, but you're still 10 minutes from the outhouse, and you need to hold your urine for a lengthier period of time. Let's say you're in the mall and it's 10 minutes to the other side of the mall, and you really need to go. You need to be able to hold the urine. So you need the slow twitch muscle fibers as well as the fast twitch. But it's important that you both squeeze and you relax, because if you're only ever squeezing and you're not relaxing, you're not going to get very far. You have to squeeze and relax, squeeze and relax. Everyone needs to find their own method of doing these exercises, their own schedule. I think the most difficult thing about doing the Kegels, well, two difficult things. One is remembering where they are, finding them, and then one is remembering to do them, because it's easy to forget. I always suggest just do 10 at a time. Don't worry about doing 50 or 100. You'll get bored and distracted and frustrated, so 10 at a time. So if you don't have much time, do 10 quick ones. If you have a lot of time, do 10 slow ones where you squeeze and relax for a count of 5 or a count of 10. And it's important to do them, to commit yourself to doing them every day the rest of your life. They're as important to your bladder and rectum as breathing is to your life. So you need to do them every day forever. You need to find those muscles, strengthen them, they'll get stronger, they'll get thicker, and then after a period of time, they will do the job better. They won't improve overnight, but they might improve after a month or two of exercising them faithfully and consistently. So this kind of schedule would work. I'm trying to fit 30 minutes of daily exercise into my busy schedule. Today I took 120 15-second walks. Now, not so good for your heart if that's what you're working on and strengthening, improving, but this kind of a schedule for doing your Kegel exercises would be ideal. A suggestion is just to do them when you're watching TV. If you're a TV watcher, watching football games, hockey games, do them during the commercials. If you can sort of associate them with a particular time. Sometimes with women I say, whenever you finish emptying your bladder and you're cleaning up and leaving the washroom, washing your hair and putting your makeup on, do them then. So you can associate them with something, so it just is a reminder to do them on a regular basis. A couple of things I do have, and I give credit to the president of the Nurse Continence Advisor Association, because she sent me these, or a template of them, just a pamphlet on doing the pelvic floor muscle exercises, and she also sent me this video clip, which I'm going to attempt to show to you now.
Your urologist has sent you to see me so that I can teach you some things that's going to make your life a lot easier when you recover from the prostate surgery that you have in a few weeks' time. I see a lot of men like yourself, and we've found over the last number of years that if we teach you to do some exercises, that it will help you gain your control a lot quicker. So your urologist will have shown you, I'm going to just show you this picture and explain to you how your bladder works, okay? So this is a picture, a side view of a man, and this is your stomach here, and that's your bottom there, your buttocks there. This is your bladder here, and that's the tube that you pee through, called the urethra. And there's your prostate there at the base of your bladder neck. And the bladder is controlled, urine is controlled, the flow of urine is controlled by a couple of valves. One that's here, a sphincter here, and one that's about here. And they work together in a team. And they're used to working together in a team, so they're closed when there's urine present, and when you want to pee, they open. And the brain controls all of that. When this surgery is done and your prostate is removed, your internal sphincter is removed. So the remaining sphincter has to learn to work by itself. To add to that, for 2 weeks after your surgery, you're going to have a catheter in place. It's going to go in through your penis and into your bladder, which time that sphincter is going to sit in the open position, which means it's like a cast on it. So when the catheter comes out, it's got to get back in action, and it's got to get used to working by itself. So we've learned that if we show you how to contract and strengthen this muscle here, which is called your pelvic muscle, that muscle will help to provide support for the neck of your bladder and also help to provide support for this remaining sphincter, and you get to control that a lot faster. The exercise is a relatively simple one to do. It's about contracting your rectum, and this is the rectum here. The rectum is where you pass stool through, and what we want you to do is to tighten your rectum just as if you were trying to stop gas from coming out. And when you do that, it then tightens this muscle and pulls it all the way across so that it goes from front to back, or back to front rather. And it will give you a bit of a lift underneath the scrotum at the other side so that you'll know that you've done it correctly. So the easiest way to do it is sitting in a firm chair like you're in right now. And what I'd like to ask you to do is to sit back in your chair and just relax so that you can feel all your muscles are relaxed. And then what I want you to do is to try and find that muscle that you would use to stop passing down and to tighten that up. Can you feel that? And when you do, you should feel a little bit of a pull at the front underneath the scrotum. That's kind of your feedback, so you know that you're doing it correctly. So the exercise is very simple. It's about holding 1, 2, 3, and relaxing 1, 2. And you tighten 1, 2, 3, and relax. And it's important to keep breathing while you're doing it. It's not about how tight you can get it. And it doesn't matter if you hold it. It does matter if you hold it for too long, then what happens is the contraction is lost. And so what we're hoping for is this nice wave of holding and relaxing, holding and relaxing. And it's more about the rhythm. Kind of like with weightlifting. When you're lifting a weight, it isn't this. It's more about the contraction and relaxation of the muscle that's important in getting toned up. And so holding for 3 and relaxing for 3 and remembering to breathe and doing 10 of those at a time, 5 sets of 10 in a day. You don't have to do them at 5 separate times through the day. You can do them at short intervals. So for example, if you watch television, you can see the commercials of your favorite half-hour TV program and you'll have done. So that's a fairly simple exercise. It's important that you start to do it now so that you can get the feel for it. While you're in the hospital, this is very important. You're going to have a catheter in place. We won't do those exercises during that time. It will be very uncomfortable. As soon as the catheter comes out 2 weeks after your surgery, you'll start to do those exercises. And to start with, you may only want to do a few at a time so you see how sensitive it is. Because you will have had surgery in that area, and you may find that doing more than a few at a time is uncomfortable. The rule of thumb is do as many as you can, up to 10, and if you're having to cough, and do them a little less often. You're going to come and see me a week after your catheter comes out, and I'll be able to see how well you're doing with your exercise. So if you have any questions about it, then I'll be able to go over that.
Okay, so that's just a bit of a clip with Dr. Skelly instructing a gentleman on how to do the Kegel exercises, probably fairly similar to what I mentioned. The myth here is that if you drink less, you pee less, and you leak less or wet less. And that seems to be logical, and many people have said that to me. But the reality is, it's the opposite, because the less you drink, the more concentrated your urine becomes. And the actual presence of that concentrated, harsh, strong urine in the bladder becomes irritating to the bladder, and it starts to contract, that muscle starts to contract, creating that sense of urgency. I gotta go now, I gotta get rid of it. It's only been half an hour, I haven't had anything to drink, there's only a tablespoon in there, but I gotta go. So what happens is if you drink more water, it dilutes the urine and it makes it more compatible to the bladder, I guess. The bladder needs fluid to function normally. And then the bladder muscle, the bladder lining, that sensitive lining, doesn't get so irritated from this diluted urine, doesn't cause the contracting. So you need to drink an appropriate amount of fluids during the day. Concentrated urine also becomes a wonderful medium for bacteria to grow, so it increases the incidence of urinary tract infections as well. So it's important that you drink appropriate amounts of water and you don't cut back on your fluids on a regular basis to try and prevent yourself from leaking. Other things, as I mentioned earlier, irritate that sensitive bladder lining. Caffeine is a major culprit. Caffeine acts directly on your kidneys and causes them to produce urine very rapidly. So your bladder fills up much more quickly if you drink something that has caffeine in it. The second thing caffeine does is it actually affects the urine content and starts that bladder contracting because it irritates the sensitive lining. So it kind of works against you in two ways. You fill up rapidly and you have to go much more quickly because of the caffeine as well. Coffee is the biggest culprit, one of the most common drinks, and probably one that most of you drink on a regular basis. In the clinic, we always talk about caffeine and that type of thing, and generally ask a standard question, approximately how many cups of caffeinated coffee, regular coffee, would you drink on your average day? And most women, anyway, will say, 1 or 2 cups, or sometimes they like coffee and they'll say, 5 or 6. But I did have a patient a couple of years back, when I asked that question, she kind of paused. I could hear the calculator clicking in her brain. She said 36 cups a day. That's the record so far. She had a 12-cup coffee maker, which she filled 3 times a day, and that's what she drank from morning till night, and just didn't realize the connection. I'm not sure why she didn't realize it, but certainly that's a bit extreme. Now, I like coffee, and I usually have my cup of coffee a day, and I'm certainly not one to say you have to cut it out completely, but you need to be aware of how it will affect your bladder. And if you have issues with incontinence, it might be something that you're going to want to curtail or even cut down, even half and half perhaps, to decaffeinated coffee. Caffeine has approximately 140, 150 milligrams of caffeine, depending on the concentration, the type of coffee, the size of the cup. Decaffeinated has about 5, so a lot less, almost nothing. Tea has caffeine, not as much. Pop does. Coke. My husband gets his caffeine from his Coke. He drinks about 5 or 6 Cokes a day. Doesn't like coffee. So Coke is an issue, or other types of pop. And so something that you need to be aware of, and the choice is yours. I firmly believe that you are in the driver's seat of your own health, and so you need the education, the information, as was mentioned earlier, and then you have to make your own choices. Tomatoes and products and acidic juices and fruits are really the same category. It's the same acid that's in the food, making them acidic, causes your urine to become more acidic, and causes an increase of irritation to the bladder lining and an increase of contractions of the bladder. And again, a glass of juice a day is healthy. Certainly tomatoes are good for you. All these things are good for you, but not in excess. Some people, are being very good by not drinking caffeine, but water is too boring, so they drink a lot of juice, and probably more juice than they need. So a glass of juice is pretty well all you need, or definitely citrus fruits as opposed to juice. Perfect, healthy for you, but not in excess. Cranberry juice at the bottom, I'll mention that because a lot of people wonder why that's on there, because cranberry juice is supposed to be good for your bladder, isn't it? Cranberry juice is healthy for you if you're prone to bladder infections. If you're not prone to bladder infections, there is no direct benefit to your bladder in drinking more than a glass of cranberry juice a day. And if you are drinking it to prevent bladder infections, make sure you're drinking pure cranberry juice, not the cranberry cocktails and mixes of all these different juices thrown together. Not much active ingredient in there. And pure cranberry juice is actually very bitter and not that easy to find, so it doesn't taste so good. But that's cranberry juice, and the pills can be substituted as well. I can't tell you how many, because there is no standard on how much ingredient is in the pills, and they're all a different strength. So. I didn't mention alcohol. Alcohol does the same thing as caffeine. So it acts like a diuretic. Your bladder fills up rapidly. It irritates the lining of your bladder. And the third thing it does is it really tends to relax your awareness, your ability to squeeze those pelvic floor muscles. So again, for your information, and probably most of you are fairly aware of the effects of alcohol. If you have a few beers or a glass of wine or something, that you'll be heading to the bathroom a lot faster. Spicy foods. I like spicy foods. I'm not ever going to say you can't have any, but if they irritate your mouth and cause burning, they'll irritate the lining of your bladder. So the same thing. You might need to drink more water, or you might need to just deal with the effects of it, as long as you're aware that they are something that irritates the bladder and the rectum as well. Now, before I mention the importance of avoiding constipation, the best way to deal with it by increasing your fiber content. So approximately 20 to 30 grams of fiber is what you need each day. Most foods nowadays have the fiber contents actually listed on the outside of the packages. I'm sure you're all aware of the bran, whole wheat, fresh vegetables, fruits, things like that. Beans, legumes, very high in fiber. All bran or lots of the cereals are very high in fiber. So just try and deliberately increase the fiber content of your diet. It will change the consistency of your stool. You won't be straining and bearing down as hard, so it won't be aggravating your bladder to the same degree as eating a very bland diet. Smoking. The ingredients of cigarettes are actually very irritating to the bladder. And they also greatly increase the risk, not just of lung cancer, but of bladder cancer as well. So that's something to be aware of. I sometimes think that should go on the packages of cigarettes, may cause urinary incontinence. I'm not sure if that would change young people from smoking or not, but it's true. And most people that are long-term smokers are really good coughers. They develop a smoker's cough, and every time you're coughing, once again, you're putting pressure on the bladder, increasing the risk for stress incontinence. So just be aware of the effect of smoking. I mentioned medications. Some pain medications actually are constipating as well, so that's another side effect that isn't nice and can aggravate bowel movements and then affect the bladder as well. Now, we have an extensive list of other products. Sometimes people are just highly sensitive to something specific that irritates the bladder. These are the most common other products: sugar, honey, corn syrup, artificial sweeteners, all types of carbonated beverages, whether or not they're caffeine-free, can be culprits if consumed on a regular basis. So you almost need to look at your diet and see if there's anything that you have a lot of. And maybe try cutting it out, seeing if it makes a difference, and then reintroducing it to your diet. 6 to 8 cups of non-irritating fluids is what we recommend on a daily basis. You shouldn't be drinking it all at once in one sitting, but throughout the day. We recommend water as the very best fluid, but certainly there's lots of others. And I'm not suggesting, as I said earlier, you cut all the other stuff out of your diet, but just be aware of the effect. So you need to sort of drink water sporadically. Now, it seems that people are either addicted to water or they simply don't like it at all. So not many fall in the middle ground. Some people drink too much water. I had a phys ed teacher who drinks about 30 cups of water a day, because if 8 is good for you, certainly 16 would be better. And 4 times that much would be 4 times as better. No, it doesn't work that way. It has to be the balance, so you have to drink the appropriate amount of water that your body requires. Now, if you're up at night, which is a very aggravating problem, it's actually considered normal to get up once or twice at night. Not nice, but normal. And there's a few reasons for that. It gets more common as we get older as well, because we have diuretic hormones in our bodies that, I don't know why, but I think they get days and nights mixed up, but they actually cause you to put out more urine at night than during the day. And you can't change that, but if you're aware of it, then you'll understand it a little bit better. It's absolutely okay to cut back on your fluids after supper if you have trouble getting up at night. That might help a little bit. The other thing is we tend to retain fluid in our lower limbs as the day goes on, simply from gravity. Things settle down there. Sometimes you notice your feet and ankles are swollen, sometimes you don't, but there is extra fluid that accumulates in the extracellular spaces. And so when you lie down at night, it can all drain back. It doesn't have to go uphill against gravity. It drains back much easier to the kidneys and ultimately to the reservoir, the bladder. And so if you elevate your legs in the evening, watching TV, reading a book, chatting with someone, it's healthy to elevate them to the level of your hips. So some of that drainage can actually occur in the evening. And perhaps you'll go to the bathroom once or twice more in the evening and once or twice less at night. So that is something, a strategy that we often recommend that can be used, as well as compression stockings, that type of thing, to prevent the fluid from accumulating. The other thing you need to try, it's kind of interesting because it sort of puts a new idea in your mind, is when you wake up at night, and I've been there, done this, you think, oh, I'm awake, I might as well go to the bathroom. So I get up and go to the bathroom, and didn't really need to go, but I was awake, so I might as well go. And that becomes a pattern. So every time you wake up, you just go to the bathroom because you happen to be awake. So what you need to do is ask yourself, do I really need to go to the bathroom, or can I just roll over and go back to sleep? And you break that pattern, that habit of getting up to the bathroom every time you stir and sort of partially awake. Because we do have sleep cycles that bring us closer to the awareness portion as we sleep throughout the nights. So think about that. And if, in fact, you do really have to go to the bathroom during the night, and you have trouble making it to the bathroom, before you even roll over, start doing some Kegel exercises. Regain control over the muscles so the bladder won't start leaking out. And then as you roll over and as you sit up, do some more Kegel exercises, and then do them as you're getting to the toilet to prevent any leakage if, in fact, it is urgent for you. So just a couple of tips there. As I said before, weight doesn't cause incontinence, can make it worse. Losing weight may help, but we can't guarantee how much. A few good habits for the bladder. Avoid pushing to pee. Now that can be difficult if you feel like you're not emptying completely, but there's a technique that we teach some of our patients, and that is when the flow of urine slows and stops. You know, it starts to flow and then it kind of peters out. And generally at that point you think you're done, you leave the bathroom, but then you need to go again shortly after. Don't leave the bathroom yet. You might want to stand up, shift your weight, change position, sit back down, lean forward as the diagram shows. Take your fingertips and put a bit of pressure on your lower abdomen, just above that pubic bone where the bladder is located. Lean forward and often another stream will start. It may not be as strong or last as long, but it will help you to empty more completely. And we call that double voiding, and the fingertip is called the Kegel technique. So give that a try. Some people do that even 2 or 3 times. So the rule is you take your time in the toilet, not an hour and a half, but you take your time, and let the bladder muscle do the job. Don't strain and bear down and push to do the job. You shouldn't be doing that for a bowel movement. You shouldn't be doing that to empty your bladder. Your goal is to empty every 3 to 4 hours, not every half hour or not once or twice a day. 6 to 8 times in a 24-hour period is considered the norm. So you might want to just keep track for a couple of days and see how you're falling, and if in fact you do hold 3 to 4 hours. Now the other thing is you have to sort of balance that with what you've been drinking, the coffee or whatever else you've had, and the amount of fluids as well. Empty your bladder before and after intercourse, certainly before going to sleep at night, and drinking adequate and proper amounts of fluid. So a few good habits for the bladder. Now urge control techniques. So what happens when you're going about your day and that urge comes and it hits and it's so hard that you can hardly stand it. You do that dance, you know, where you're trying to squeeze and hold on the way to the bathroom. Urgency is the normal signal that you get, but that urgency signal can come far too often, far too frequently, and get very, very strong. So the good news is that you can retrain your bladder to hold urine for larger periods of time. So you're going less frequently and voiding every 3 to 4 hours. It is attainable for most people. It's helpful to be keeping track as you're working on this process, but the urge control techniques include the following. So instead of making a beeline for the bathroom when that urge starts to build, what you should be doing is perhaps stopping what you're doing and sitting down, sitting still. Pressure on your pelvic floor is helpful. Do some Kegel exercises again. Research actually shows that if you're doing those exercises, the bladder muscle contractions will settle down a bit. Relax everything else and focus on something different, like counting backwards, even counting backwards by 7s. That's a little harder, takes more concentration. And then wait until that urge settles down again. And if it's been 3 hours, then you can walk to the bathroom with greater control because you've taken control of it yourself. Or you can wait until longer if it's only been a short period of time since your last major trip to the bathroom. So you need to sort of use these urge control techniques during that strong contraction, that wave. Wait it out and then see if you need to go afterwards or if you can wait for a longer period of time. Bladder retraining is the actual process over a period of time in prolonging the time between trips to the bathroom, so the frequency. And it's done on a weekly basis. Now, not everyone is in the position or has the lifestyle to be able to do this, but if you do, it has been shown to be effective. So it's just simply a method of retraining your bladder to hold larger amounts and to decrease the frequency of trips to the bathroom. So week 1, you'd have your starting point of approximately how often you're going. So if you can hold for an hour, you'd start at an hour. So during the day, you go every hour, on the hour, whether you need to or not. At nighttime, you just carry on normally. Week 2, then, you'd extend it by, say, 15 minutes or even 30 minutes if you can. So you're going every hour and a half. So your bladder has to wait a little longer, has to hold a little bit more. Week 3, you'd extend it again. And so you can get the picture that over time, you're gradually getting your bladder used to a different pattern, and you take charge of it instead of just running every time it tells you to run. There are medications for urge incontinence or overactive bladder. There are no medications for stress incontinence, unfortunately. So as I mentioned earlier, the Kegels are the main therapy for stress incontinence. The medications for overactive bladder also affect different parts of the body. So the side effects can be somewhat aggravating. These medications, I'll just list a few, and you might be able to recognize a few that your doctor might have tried you on. Oxybutynin, Detrol, Ditropan, Vesicare, Enablex. There's a few new ones on the market as well. Now, some people find them very helpful, and they don't cure urge incontinence. They simply control it. So if you go off of them, you'll still have the same symptoms. But what they do is they prevent that constant urgency, that contraction of the muscle. So they settle the muscle, the detrusor muscle, down. The most common side effect is dry mouth. And in Calgary's dry climate, that's not always welcomed. And that tends to be the main one that people discontinue the use of these medications for. Now, they affect some people in a stronger way than others, and there's others, different ones you can play with now as well. They may aggravate constipation. They may affect your eyes. You might notice they're a bit drier as well. Surgeries for stress incontinence, really, there's really just the artificial sphincter, so it's a fairly extreme surgery, and I don't think it's done very often, but for very severe cases, it can be done. It's something your doctor would have to recommend you to a surgeon or urologist for. So it fits in there. The inflatable cuff is around the urethra, just underneath where those muscles are. There's a pump located in the testicles and the scrotum, and then a reservoir as well. So what happens is that when you squeeze the pump, the cuff inflates and prevents the urine from leaking out. And then when you squeeze the pump when you need to go to the bathroom, you squeeze the pump again, it will deflate and go into the reservoir temporarily while you're emptying your bladder. So that's simply how the artificial cuff or the artificial sphincter works. Now, there are products that can be used, of course, if you need to manage them. I think it's important that you don't think these as you're resorting to these, this is the end of the road, but they are something that can be helpful while you're working on your Kegels and trying all these other things. Just make sure if you need to use some padding to catch any drips, you're using pads that are designed for urine. And there are specific products designed for men as well. So Tana is one of the companies. There's certainly others. Most drugstores, grocery stores, Costco, you name it, department stores, they all have incontinence products. They hold 4 to 6 times as much urine than regular female pads for their periods do. So they actually wick the urine from the surface and turn it to a gel, so they're not wet and soppy and stinky, and they're much more comfortable. So just sort of something to keep in mind if you are finding that you want to stay dry in certain occasions particularly. So in summary, I guess, avoiding caffeine, drinking more water, doing your Kegel exercises, talking to your doctor if you're interested in any of the medications or the sphincter surgery. So that's it for me. So do you have any questions at all that I can help you with? I'll just open this up again. Yes? Sorry, in the back?
You talk about when there's the urge to void, doing contracting and relaxing the pelvic floor muscle. Not just contracting, you're not just sort of squeezing down on that sphincter, but just contracting.
Squeeze, relax. If you try to squeeze it for too long, you'll lose it. You'll lose that tightness. They'll slide away. They'll get weak. You can't contract it forever. So squeezing, if you hold it for 5 seconds, you're able to do that. Relax for seconds. Go back down to the bottom level. Squeeze again. Go back down to the bottom level. So that's really important. If you just squeeze, they'll go back down whether you.
The muscle gets quite tired.
Very tired, yeah, and not as effective. Yes.
Are there some? You mentioned caffeine and certain things that irritate the bladder. With me, anyway, coffee is definitely the worst one. Red wine and cranberry juice. Those 3 things.
So he's validating what I just said. That's
Yeah. But cranberry juice was down low in your listing. And with me, it's way up high.
It's really up there. I don't know how many people drink cranberry juice on a regular basis.
I used to.
You used to, so you've cut back on it. That's interesting. So that really does say what I've been trying to tell people. So,
You can drink beer.
Pardon?
You can drink beer.
Yeah, you didn't mention beer.
As a matter of fact, beer works well with me.
Is that right? So it's not so bad. And I think that's because we are individuals and things are a little different from person to person. Yeah. Yes.
What about tea? Because that has some caffeine.
It does. It has about half as much caffeine as coffee. Green tea has caffeine. A lot of people are drinking green tea because it's good for them, but it does have the caffeine as well. Iced tea has caffeine. Some people actually claim that tea is worse for them than coffee. There are some other ingredients of tea which might affect people in that way, so tea may be a worse culprit for some people. But definitely tea has caffeine. Yes?
When you say 6 to 8 cups, is that different than 6 to 8 glasses?
8 ounces.
8 ounces?
Yeah. That's a good point because a cup can be a little cup or a big cup, and I mean the actual 8 ounces.
And your comment about full bladder confirms what I found. Bladder's full with no leakage, which I thought was a little strange until you mentioned it tonight.
Yes?
What is the normal cost of a bladder then?
It holds about 1 to 2 cups.
One to
About
two.
350 to 650 milliliters is the normal capacity.
What was that? What did you?
About 1 to 2. How much does a normal bladder hold? About 1 to 2 cups, approximately 350. And you usually feel the urge to go when there's about 250, about 1 cup or so. You start to feel like you need to. You don't usually wait till it's totally full to go, though. I mean, because it can stretch and stretch. Generally, most people empty their bladder when there's about 500 mils or about 1.5 cups or so in the bladder. That's when, if things are normal. If things are normal. Yes?
Could you go over the double void technique again?
Sure. You sit down, you pee. You stand up, shift your weight, sit back down, lean forward, take your fingertips, put some pressure on the bladder, and the flow will start again. Won't be as strong, won't last as long, but you'll empty a little more completely. And then you'll feel more completely emptied when you're finished. So just sort of taking a bit of extra time because that detrusor muscle starts to contract again. That's what happens. Anybody else?
No more questions? Thank you. Thank you very much.
You're welcome.